Welcome back to the channel. Today's video is going to be on what residency looks for in medical school applicants and what residency should look for. A few weeks ago I did a video about medical school application and what people look for and what they should look for. That was surprisingly popular. I got so many emails, LinkedIn requests, people following me on Instagram wanting to discuss that video. They asked to do a follow-up video about the next step in the journey, going from medical school to residency. Of course, by way of background, I'm a professor here at the University of California, San Francisco. I've been a professor for about 10 years now, and before that I trained at University of Chicago and Northwestern and the NIH in oncology. Then I moved to the Oregon Health and Science University for my first 5 year on faculty. I've been here for another 5 years. And in that time, I've seen a lot of discussion of medical school applications, residency applications, fellowship applications, perhaps the most about fellowship, which we'll come to in a future video. And I think I have a sense of what people look for, and I think I also have a sense of what they ought to look for and all the ways in which the current system is really stupid and time-consuming and pointless. So let's get into that. The other nice thing that happened today is this morning I had a team meeting with my research laboratory, and there are a couple of people applying to residency right now, and they filled me in on all the details about signals that didn't exist back when I did it. All right, well, what does residency look for? They look for a few things. One is they look at USMLE scores. Back when I did it, we had a USMLE Step 1, which people put a lot of stock in. The Step 1 is now pass-fail. That's a victory, some people think. I would have rather seen the content of Step 1 be changed, not that it become pass-fail. But be that as it may, Step 2 is now routinely used as a measure of sort of cognitive ability, test-taking ability, and it is a score relied upon by many training programs, the Step 2 score. I think that's actually probably pretty reasonable. Step 2 questions are, for the most part, okay. There's a video on this channel where I go and actually do some in real time with a bunch of attending physicians, and we have our quibbles about some of them. But Step 2 questions are mostly okay, I think. Maybe half okay, half not okay, but much better than Step 1, which has nothing to do with being a doctor, nothing to do with anything really other than memorizing useless trivia that a few people who don't want to resign their positions in med school want you to know. The next one, letters of recommendation. Letters of recommendation, my source tells me, they say one letter will be from the department chair or from some senior person in the department. One letter should be from somebody you worked with clinically, and then a couple letters speaking to different attributes of your training. I always write a few letters each year talking about students who did research with me or came to clinic with me. Letters of rec, they put a lot of stock in. I read online that it says, it's best to choose a letter writer who knows you well and experienced in the field and well-known by program directors. Oh, great, sure. Well, to me, letters of rec is one of the stupidest things we do. It's something that takes up a lot of people's time. We do it every single year. So many people write letters of rec, and it's fundamentally a flawed premise because, of course, anybody, even the worst performer, can find 3 people who are willing to say you're decent or good. The hard part is, what does the average person who work with you say? What does the full distribution of people who work with you say? Finding 3 letter of rec writers, you have to be severely bad, severely compromised as an applicant to not even be able to find 3 people who say, hey, you came on service and you did an okay job. To me, letter of rec is not useful at all. I certainly think I would put no stock in the fact the letter of rec is being written by, I don't know, the dean of Cornell Medical School, for instance. That would give me no stock. But I do think the average person who works as a program director is easy to be bamboozled by those kinds of trappings. And so a strong letter from some big name person like the chair of a department would go a long way. I do think that one thing letter of rec writers should write, and people do respond to, is if they say that in the last 10 years I've worked with 150 students in this role and this person's in the top 5 of them or 3 of them or 2 of them. If you can get something like that, I think it'll help you. But of course you can't control that. What can you do about that? They're writing the letter. If they don't know how to write a letter, then it's probably not going to be so great. So even more than knowing you well, experienced in the field, and known by others is, do they know how to write letters? And who knows the answer to that question? Somebody told me that in their school, there's one person who's known for writing really good letters. She has a process where you have to submit information to her. You sit down and talk to her, and then she writes the letter only in response to that. To that person, I say, well done. I also say, what exactly is your job at the university? Because I think any one of us who's seeing patients and doing research that we think will change the lives of patients, we don't got time for all this stuff. I mean, to actually meet with somebody, go over the CV, and spend all this time drafting this letter, it's preposterous. It's something that you got to do quickly if you have time at all, and I think that's the reality for most faculty. Unless, of course, you're not doing anything. I don't know, if you're not seeing patients and you're not doing research, then I don't know what the hell you're doing. You got time to write these letters. To me, letter of rec, they should throw it out. But unfortunately, it's in for now. Find letters from people who are actually going to write something that's in any way memorable about you or some anecdote you did, rather than just rehash your CV. I suspect that the best surrogate you have to decide who to write a letter is how good a conversationalist they are. And if they're not great at conversing, they're probably not great at letter writing. The MSPE. This is something that I think is actually important. It should be important. It is probably the most important thing. In my world, I think you could do away with a lot of the other stuff and just go to the MSPE. The MSPE is basically a very formulaic letter produced by the dean that summarizes your performance in medical school. There's a lot of, hidden vocabulary in there. I think sometimes the words satisfactory, outstanding, and excellent are code words for some sort of scale that you may not be privy to, but it's written in a very formulaic way, and it draws in quotes from people who worked with you on the different rotations and is thought to try to be an objective midline view of how you did on service. And to me, probably the best predictor of how well you'll do in an internal medicine residency is, did you do a decent job as an internal medicine clerkship student in third year? The MSP has a lot of weight. It should have a lot of weight. I think you get a chance to review it. You should try to make sure it's written cleanly and succinctly, and maybe dispute anything you think is even at all pejorative in there. Grades. Grades are good. I mean, I think you get grades. I know some people say that grades are biased in this way, that way. I'm sure they are, but what is better than grades? Is a standardized test that tests your ability to memorize esoteric factoids better than grades? I think that's even worse. Is more research publications better than grades? Not really. That just tells me you're connected to people who are prolific research mentors. It often doesn't tell me anything about your own aptitude at research. So to me, as much as we malign grades, they're probably the best thing we do have. Some schools still have grades, The very premier schools of this country have moved away from grades because they're punch drunk on some diluted ideology that says that grades are not able to be used in a constructive way. But they've just really merely incentivized the mass production of low-quality research instead. So they've made their own mistakes. But the places that still have grades, I think grades do count. And insofar as they are pegged to shelf examination scores, I think that leads to some discriminating ability, and that's something that people will put stock in. Research. On the ERAS application, the research is divided into publications, peer-reviewed publications, posters, presentations. For students, maybe you feel like just getting your foot wet with a poster was good enough. It is, but of course peer-reviewed publications are the only thing anyone really cares about in this business, and the longer you do it, the more you could take off all the posters in the world. It's not going to help you. But for this, I think it's good to just have a few things that people could talk to you about. Now, if in a perfect world, would I even include research? Absolutely not. I think it's pointless and stupid to make a medical student whose first and foremost job should be to learn the practice of medicine correctly, to make them do superfluous and low-yield research on often in vogue and buzz-worthy topics that have no long-standing durability and methods that are so weak, it's like a piece of parchment paper. I mean, to me, that's the biggest misuse of their time, but unfortunately, for the time being, research is a part of what they look at. I suspect competitive fields like dermatology value this greatly. Research, sub-I evaluations from places like, for instance, orthopedic surgery would value a sub-I experience, letters from a big name in derm. The people in the competitive fields, they often get on their high horse. They talk about how many applications they get and how selective it is. I think they should remember that if dermatology had the same reimbursement as infectious disease, the same dollars per hour as infectious disease doctors, it would have the same absolutely low rate of people going into it. Nobody would want to do it. The only reason some of these fields are competitive is that they've gerrymandered the RVU system to make horrendous amounts of money with very little work compared to other fields and very little on-demand work. And that's why things like urology and dermatology are so competitive, because they've gerrymandered the RVUs, not because there's anything magical about doing surgeries in the urethra versus doing it in the ear versus doing it in the throat. These things would all be equivalent were it not for the fact that they've gerrymandered. Some things I do think are intrinsically more competitive, long-standing. I think neurosurgery, cardiothoracic surgery, cardiology, because these are the sort of most, historically interesting aspects of the body and the things that I think little kids still dream about being a cardiac surgeon. I don't know if anyone dreams about doing vampire facials, for instance. Okay, all right. Let's talk about the next statement, personal statements. Personal statements. Oh, I saw somebody write a very interesting personal statement, put it online, and they said this is a good example of a personal statement. I'm going to read a little bit of that to you. I think it's terrible. I think personal statements, you're much more likely to shoot yourself in the foot by being too adventurous or ambitious or even too honest, and you're much more likely to lose an opportunity than gain an opportunity. So your personal statement should be pretty down the middle and bland. But in a perfect world, we shouldn't even write personal statements. It's really stupid that we do. People who are more connected to other people can get more attendings to read it. You might even get ChatGPT to draft it for you. You can even get somebody else to write it for you. Nobody knows. Personal statement, who even says it's you who wrote it? It's the worst part of this application, and people dread it. They put it off. They postpone. They procrastinate. I say you just sit down at the computer right now. You're thinking about it. Write it in 5 minutes. I think just write it. Just write whatever you want. Or just turn your phone on dictation and just dictate something. You say, the reason I want to do insert specialty is because of X. I first got interested in it, put some anecdote in, and say some of the experiences that I think bear weight on this field, or put 3 paragraphs, you're done. Just write some crap. And then have somebody edit it. That's probably what most people are doing. And if I were in charge, I would delete it entirely. I think it's pointless. And notably, like people who are actually practicing doctors and faculty, we don't really write personal statements. I mean, every once in a while for my promotion, they say, write where your lab is done and where you're going to go in the next 5 years. It's not like a personal statement, and no one holds you to it. And needless to say, you don't follow it anyway. I think personal statements are stupid. Relevant skills and experience. I hear you can put 10 experiences and you get so many characters to describe that, and then the 3 most meaningful experiences, you get some extra characters to describe that. I assume there's somebody out there who's got the time to read all these experiences and care about them, but I suspect that most people don't have that time and they don't care, and so you can just show that you've done a little bit of one thing, a little bit of another thing, and write some bland or trite thing and just move right on. Personality and culture fit, interview day experience. The interview day has been ruined. It's been ruined because these programs realize that they don't want to actually invite people to come and tour the facilities and get a sense of the place, and so they do it all by Zoom. And I think people celebrate that. They say, well, it cost a lot of money. I think I spent like $6,000 just interviewing for residency. At the time, I didn't have any money. I took loans out for that. I had to pay back those loans. So with interest, that cost me a fair bit of money. At the same time, as bad as that was, it was useful because I wouldn't have paid to travel to places I wasn't really interested in going. So that was the old-fashioned signal. You actually had to foot some bill to go there, so it meant you probably wanted to see the place or you cared about it a little bit. Second, there's something very valuable about actually sitting in someone's morning report and seeing the culture of the place and seeing where the residents sit and being able to look at them when they don't think you're looking at them and see how tired are they, how energetic are they, do they seem happy, what's their camaraderie like. You gained a lot by going to places. And even if you didn't end up there for residency, you remember that when you went for faculty. I think I had a great residency interview at Oregon Health and Science University. I didn't go there for residency. I went to Northwestern in internal medicine. But it was my first place on faculty. And actually, the program director remembered me well. And actually, we, rekindled our friendship when I was a faculty member there. So it's interesting to see places. I probably wouldn't have applied to it as a faculty member had I not had that positive experience as a resident. So I think that that's something that they've done as a disservice. Zoom-based interviews. So you sit there, obviously with pajama shorts on because no one sees you from below the waist, and just wear your shirt top, and you give some horrific answers looking straight into your Zoom camera, scared to look away lest they think you're inattentive. I could not imagine a worse interview process. Horrific. Horrible for both the interviewee and the interviewer, regurgitating the same nonsense. One way they could make it better is they could have if you're going to do Zoom interviews, why do we each do separate interviews? Just come up with 10 standard questions in the field and have a single interview and send that interview to all the residency directors a video that they can watch. Why do you want to go into dermatology? Tell me about a challenging experience you faced and how you overcame it. Blah, blah, blah. And then maybe if you want some personalized question, you can ask them that to your applicant, Describe the research project you did. It doesn't have to be personalized. Which is the research project you did that was most important to you? And if you don't have a research project, what's the quality improvement project you did most important to you? See, you could do this in a single standardized way so people don't have to repeat themselves over and over. I actually think there's a lot of literature on whether or not interviews predict job performance, and depends on the question, But those kinds of questions like what are my strengths and weaknesses, tell me about a difficult situation, how you overcame it, they have a very poor predictive value over first-year job performance metrics. And once on an interview when somebody kept asking me those questions, I pointed that out to him. He didn't like to learn that fact, obviously. That didn't go well. But of course I didn't. You can only do that when you've decided already you don't want to go there. All right. The signals is interesting to me. These didn't exist before. In internal medicine, you have 15 signals, 3 golds and 12 silver. Some really good places like MGH, they don't accept signals at all. Signals, the the equivalent of actually going there. It's pretty stupid. Actually, it's pretty stupid that they do this, but they have to do it because they're going to be inundated with applications. They're going to get a lot of applications from people who aren't really serious about that place. Geographic preference, you can ding 3 regions. This is all a really ridiculous process. You might ask yourself, why is it like this? Why is residency this system where you apply in such a formulaic way? You've got these signals, you do this interview, and then you get a rank list, and you get a match day, and you get matched into a program, and if you don't go to the program you're matched in, I think they ban you from the NRMP match for 3 years or something like that. Why does it exist this way? But yet, when you finish Hem-Onc fellowship or cardiology fellowship, nobody gets a job that way. When you switch from the first to second job, nobody gets a job that way. Why does it exist this way? Well, it exists because the hospitals, which are greedy nonprofits, which put the profit in nonprofit, whose nonprofit status should be rescinded because they're pocketing so much cash and using it in such aggressive and predatory ways, they don't want to be short even one resident on day one. They want a fully working labor force. So they violated the antitrust agreements and they violated antitrust law to create the NRMP match, which is a monopoly on first jobs outside of medical training. But that monopoly is spared from litigation because George W. Bush signed a bill that actually exempts NRMP from antitrust litigation along with Major League Baseball. And that antitrust rules allow the residencies to have this stranglehold on pay and things like that. Now, every once in a while, there's some residency union that proudly says, we got people $10,000 so everybody in this residency can freeze eggs and sperm or something. That's a true thing. That's something they bargained for. Or we got you an extra $1,000 a month, living stipend if you live in New York City because it's horrendously expensive. That's what, they may bargain for. But the truth is, it's small bargaining, and if you really had a free market of jobs, I suspect that the differences would be even bigger. There'd be some applicants that probably are so good, people know they're good, and you've worked with them and you want them so bad, you might make them a very enticing offer to be your resident because you know that person is really reliable and good. So it's hard to imagine what a world would look like without NRMP, but I suspect in many ways it might be better. And then as for this worry we won't fill all our spots, I think that worry is really misguided and silly because we have a huge influx of international medical graduates who can pick up empty spots. That's 1. 2, we always have unmatched people who can pick up spots. And 3, we don't have that problem elsewhere in first-year faculty positions nor in medical school spots. We fill these spots. You can fill the spots in the absence of a match. And then the final point about matches, the match algorithm, for which Alvin Roth won the Nobel Prize, is not an optimal algorithm. It's suboptimal, meaning that the algorithm does not minimize the cumulative number between programs and applicants so that 1 is 2, 2, 2, minimize that number so that everyone gets their most preferred thing. They say it preferences the applicant. I'm not sure it does that at all. It's run multiple times from different starting points in the data set, giving slightly different match results, and then the most parsimonious one is picked, which is still extremely suboptimal. And if you can imagine sort of a topography landscape, you're really just solving for sort of a local maximum and not the global maximum in the whole topography, if that makes sense to the math people out there. Anyway, it's got a lot of problems. So back to what I wanted to talk about in this video. So what do they look for? They look for these things. They look to see, did you signal my geographic preference? Did you give me a gold or silver? Did you flirt with me a little bit? Show me you're interested. Did they... the program equivalent of flirting? Did you have research publications of dubious quality or value? Did you write some bland personal statement? Do you have some experiences you highlight? They look for all those things. They shouldn't look for any of those things. They should just look for a truly average summary and score of your performance on the clerkships most relevant to the job. So if you want to do medicine, they should just get everyone's eval, everyone who worked with you on medicine, and get all of that or a summary of that written by someone who's impartial. That's probably the only useful thing, and maybe your step score a little bit. That's all they should be getting. And all these competitive specialties should have a recalculation of their RVUs so that they are as competitive as the true interest in that body system demands. We shall see what that is. That would be a much better way. People shouldn't be asked to produce ChatGPT level documents. Like if ChatGPT can write a personal statement, which it can. In fact, this morning we actually did that as an exercise in my group, and it actually wrote a pretty decent one. If it can do that, it's a pretty useless thing for someone to do. What the person should do is what ChatGPT can't do, which is actually the job of being a doctor, which is what ChatGPT obviously can't do. It would kill a lot of people and confabulate worse than the greatest confabulator already admitted to residency. I do think it's a mistake that we don't have people go in person. You could delete the whole signaling process and have people go in person, put your money where your mouth is, and literally show your interest in programs, and you gain something too. So that's, I think, the difference between where residency selection is and where it should be going. A final thing I should say. This may offend some people, but every once in a while I hear that the residency is, I read this online recently, it's biased against DOs, or it's biased against international medical graduates, or it's biased against doctors from the US who did allopathic medical training in the Caribbean. I think you have to be careful what it means to be biased. Okay, bias means that they don't like those people even after adjusting for all the known predictors of how well they perform in their job. Not that they don't like those people because some of those other predictors are way lower, like they have lower step scores, etc. That's not bias. That's actually part of why they're not giving you the interview. A few things to say. One, I think if you look at all nations globally, you would see that probably the United States is actually the single most lenient nation in allowing people who trained in other countries to come here to do residency. We're better than Sweden and Switzerland and the United Kingdom. We're probably the single most lenient nation. So that's already a very real big pipeline. And of course, if people say it's not perfectly fair, well, of course, it's not going to be perfectly fair. No one country can take the doctors from every doctor in the world and allow them to come practice medicine in that country. It's just not going to be fair. So of course, they're going to try to pick the best people, and they're going to rely on step scores and all those things. That's life. I don't know what to tell you. It's a competitive business. So of course, that's going to be the case. DO, of course, on average, the people who get into a DO program but not an MD program and choose to go to a DO program probably had lower scores in college and on standardized testing before that. Of course, they're going to hold that against you. So you have to be twice as good to get out of that. And then if you actually plot the distributions of all these things from MD doctors to NPs to DOs to whatever, I think one truth remains. There's much more overlap in the distributions than there is difference between the means of the distributions. In other words, that the single best DO doctor, I guarantee you, is better than the worst allopathic MD doctor and probably better than the average allopathic MD doctor. The single best Caribbean doctor is way better than the average allopathic MD doctor. The single best nurse practitioner is probably way better than the average MD doctor, okay? That's the whole point of the distribution. The distribution is broad. There's some people who are excellent from every one of these pathways, but the means can be different, and these programs don't know. They don't have the granularity of knowing where you are in the distribution. They have to rely to some degree on the means, in part because these metrics that they're using for residency selection are so piss poor. You know, an MSPE written by some admin in your university isn't really a perfect synopsis of your clinical performance, because it's summarizing the results of selectively submitted, submitted grades by some people you worked with, not other people. A student told me he worked for 2 weeks with somebody who he didn't respect, wasn't a good doctor, and that person didn't like him, and so he has a bad grade in his whatever continuity clerkship portion. That happens. So of course it's not a perfect distillation of where you are. So of course they're going to rely on some of these mean differences, you know. The average person, a person with a 265 step score and a 250 board score, again, if you took all those people, there's a huge distribution of their performance in both. The best 250 board score person is light years better than the mean 265 board score person. But again, there's probably a mean difference between the two distributions. That's why it's going to be leveraged or exploited by people who are forced to make tough decisions with few spots. It's a long about way of saying that Yes, there are many things we should change about this process, but some things will always be unfair and they will never be fixed. If you think that IMGs will have the same shot as somebody who went to Harvard Medical School, you're delusional, okay? You're really delusional. That's never going to happen. If you think a DO should have the same opportunity as somebody with an MD, I think that's also unlikely. You have to have better statistics to offset the fact that it is a DO. And same for somebody who went to Caribbean Medical School. And that's not to say that the best people are not great. They're, of course, terrific. I would much rather work with the best doctor with any credential than the mean doctor from any other credential. Okay, obviously that's the case. But those things will never be fixed. What can be fixed is we can delete personal statements. We can delete letters of rec. We can have a better interview process. If it's going to be Zoom-based, you should just do it once, record it, or maybe once or twice, and you pick the one you like better and send it out to all the programs. It doesn't even need to be in person. And if it's and I think we should reconsider whether or not there is a value to bringing people in person. That's how we could actually make it better. Those are some achievable changes. All right, those are my thoughts on what residencies look for, what they should look for, why the NRMP is a broken process. There's so much about medicine that is a bureaucratic, administrative, historical accident that people just take for granted, starting with the fact that derm here, ID here. Like ID did not match the last few years in derm. There's, everyone and their grandma wants to go into derm. Why would that be the case if it weren't for the reimbursement? Okay, is putting an ointment on something better than squirting some Zosyn on something? No. Okay, I think they both have some cognitive things that are interesting to me. I actually find both very interesting. I wish I was great at both. They both have some things that I don't find that interesting naturally. They both have some trash, vampire facial and giving antibiotics needlessly and not running any randomized, running very few randomized studies when you could be running a lot more ID, both fields, so they wouldn't be that different were it not for that fact, controllable hours and money. Once that reform takes place, and once specialties are incentivized based on the real public health benefit and need of that specialty, I think that's the big, real root fix. And then deleting the NRMP. That's a root fix. All right. If you like this video, you know what to do. Like, subscribe, comment, leave a message below. I will do a probably similar video on fellowship. If you disagree with anything I've said, put it in the comments. Send the video to a friend or colleague, and I'll be back with more videos on this and other topics. Until next time.